Okay. Thanks, Mitra. And this is likely a topic that many of you guys in the audience know a fair amount about. So happy to have people chat in as we go along, or just unmute yourself and interrupt me if you have a comment. So we're going to talk a little bit about the intersection of child protective services and the legal system with many of the individuals we work with. I'm going to focus on child protective services, but also highlight some of the innovations in the legal system that have improved our interactions with some of our patients in the legal system. Overview is just we're going to look at some of the numbers, which as I updated these are really striking. I mean, we know that there is a foster care crisis in this state. I didn't quite, frankly, know how bad it was, so I'll share some of those numbers with you. We certainly know that child protective services agencies and foster care agencies are overwhelmed, and the numbers support that. We'll just highlight who's likely to be involved with child protective services and a little bit about the process. Unfortunately, I've been developing, trying to improve some of our relationships with the managers in the various counties around our area. I was trying to get from them, I have the manual, I have the policy and procedure manual, but it's like 249 pages. So I was trying to get from them the outline of when things are supposed to happen. And I do not have that exactly, but I can give people some rough numbers in terms of the process. We'll talk about innovative models and specialized courts, and then a little bit of thoughts, and I welcome other people's thoughts about how to advocate for our patients who are involved in child protective services or the legal system, the court system in general, as related to their drug charges. So just some of the numbers, the latest numbers that we have are from 2020. And so 6,700 children are currently in foster care. And some of that is kinship foster care. And so when we look at the numbers between 2017 and 2022, it's 7 to 9% of the population, and we are the highest in the nation in terms of the utilization of kinship foster care, just behind Mississippi. The number of children in foster care, it's like 20 per 1,000, and the national average is 5 per 1,000. That's in 2019 and 2020. And in West Virginia, it has been increasing every year since 2014. And then child abuse and neglect. Also, we're kind of third highest in the nation. And so these are really, really high numbers. And for those of you who work with pregnant patients, we also lead the nation in neonatal abstinence syndrome rates by quite a lot. So 50.6 per 1,000 compared to 7 per 1,000, which is the national average. Really high numbers. So this is actually the NAS map, which I'm going to credit the perinatal partnership with helping out with. I know Janine is on, that helps us track a lot of these numbers. And it's also from reporting data from hospitals. But you'll see the Northern Panhandle actually has the highest rate. So it's a little bit hard to read, but that's IUSE stands for intrauterine substance exposure. And the rates in the Northern Panhandle are almost 18.5%. Now, that's not a direct correlation to babies that may develop neonatal abstinence syndrome. So the rate of babies who actually develop symptoms that qualify them for that diagnosis are much lower than the exposure rate, but still significant. So this is kind of how the West Virginia map looks. And then in terms of the problem, we know that these numbers and the increases in these numbers of babies exposed, of children in foster care, of child protective services calls have increased in lockstep with the opioid epidemic and really the substance use epidemic that we're seeing. And so they are very highly correlated. So we have, overdose. You guys have heard the numbers of overdose mortality rates in West Virginia being the highest, and we were really stayed the highest since 2009. Good news for 2021 is it looks like we have perhaps a decrease in overdose death rates for the first time in a really long time. There was a brief decrease in 2018, but then COVID hit and reversed some of those improvements. West Virginia is #1 in child removals. So the number of children that are removed from their homes as a result of Child Protective Services reports, we are #1. I did not know that until I started to prepare for this. So that's really concerning. And then, you know, kind of the percentage of increases over recent years, including adoptions. So 83% of open CPS cases involve individuals with substance use disorders. And that's really where it intersects with our patient population. So you can expect to see lots of people struggling with Child Protective Services and the demands of Child Protective Services and how to navigate the system, because it actually does vary county to county. The general process of becoming involved with Child Protective Services is there's an initial report. Sometimes that's done by the hospital. So in the case of, say, a pregnant individual and they deliver, the hospital might file that report, or it could be a neighbor or a family member filing a Child Protective Services report. And then depending on the severity of the report, the acuity, the risk, is then going to determine how quickly CPS goes out to the family's home or reaches out to the family. So it can be anywhere between 24 hours and a week, just depending on, or the report could be discounted and they would not be visited at all. So there's a lot of variability. In terms of removal, also lots of variability depending on the level of risk and safety issues. So there's a number of days after the report and the report being indicated that a court date is supposed to be set, especially if there's a removal. I cannot figure out what that number of days is. It seems to vary depending on who you talk to. Some people say 10 days, some people say 14 days. We know that it doesn't always happen that quickly, but it should be within the first month. And then MDT meetings, which are the multidisciplinary treatment team or the multidisciplinary team meetings that occur with Child Protective Services, usually the guardian ad litem, sometimes prosecuting attorneys or attorneys for the patient, the client, and then the client are invited to those meetings. They can also have advocates. And so if we are able to be an advocate at those meetings, we can sometimes get access to being able to accompany them. A lot of these meetings are on Zoom at this point, so it's a little bit easier to accompany our patients. And then visitations usually get scheduled at some point. Again, there are all kinds of rules about how quickly this is supposed to happen, especially with newborns, but I've had a lot of difficulty getting access to exactly what the guidelines are. Often they're urine drug screens, so people have probably heard the familiar complaint from many patients is they call every day and they are given a color, and if their color is pulled, then they have to present for a urine drug screen. And sometimes this is up to 3 times a week, which for patients who have no transportation can be really, really challenging. So that can be a struggle. And then at generally, Child Protective Services and the state requires that CPS cases be resolved in 18 months or up to 2 years. They can be extended, but in general, they want to see a resolution in 18 months. And that will be, the child gets returned to the parents. There's a termination of parental rights or a disposition 5, which is, it's sort of a voluntary relinquishing of parental rights. So it's not the same as a termination. And it can be temporary is the other thing. Often this will happen with family members. So a disposition 5 can occur when the patient says, okay, I'm not ready to get my kids back. Maybe someday I will be. And in the interim, I'm going to allow my cousin to have custody of my children. During that 18 months, all kinds of services are usually recommended. That includes parenting, birth to 3 services, sometimes couples counseling, sometimes anger management, depending on the situation. And CPS is really in charge of coordinating those services. We, as the treatment providers, may be part of those services that are required, and hopefully CPS coordinates with us. But we know that communication is sometimes difficult. So just a little bit about Child Protective Services and pregnancy. In this state, you actually cannot file a report on someone who's pregnant and using substances, and as a result, putting the baby at risk if they do not have any other children in their custody. The CPS won't take that report because it's not considered a person while the woman is still pregnant. All pregnant women who do give birth and test positive for substances, including prescribed buprenorphine, are reported to CPS. And what CPS does with that information varies a great degree. Usually they come to the hospital and meet the patient. And sometimes nothing happens after that, and there is no more contact and a case is not open. Sometimes there's sort of a temporary case, and the CPS worker might go to the home and follow, the patient and see how they do for a couple of months, or just go to the home once, everything looks good, and never open a case. And then in other instances, a case is opened if there's concern about the home and safety of the child. So it's highly variable how that goes. The response to a positive test at delivery varies a little bit county to county. So this is a positive urine drug screen. Usually women at the time of delivery are tested. They have a urine drug screen testing, and then cord blood is tested. That's pretty mandatory around the state. And cord blood generally can capture substances that have been used in the last 20 weeks, although if they just used benzodiazepines once in the last 20 weeks, it's not likely to show up, but regular use will certainly show up. Usually a positive test at delivery can often result in the child, in CPS taking custody of the child, even if the patient is in treatment. So one of the things that can be at play is stigma. So I always like to just make sure we're remembering about the ways in which our patients are stigmatized by the court system, by the child protective system, by the healthcare system, and for us to be advocates whenever we can. So some good news about some innovative programs. One of the frustrations that I certainly have as therapists working with patients who are involved in the child protective system is that I have a lot of trouble reaching CPS workers on the phone because they have way too many cases and are super busy and can't call me back. And they can't call their clients back either, which is frustrating for our patients. So there's an innovative model called START. And this is a model based on the Kentucky. It was developed in Kentucky, and it stands for Sobriety, Treatment, and Recovery Teams. And so all of these systems involved with the patient are actually on one team and have regular communication. This is currently being piloted in 5 different counties: Fayette, Kanawha, Mercer, Putnam, and Raleigh County, and it's grant funded in part by Bureau for Social Services, the Office of Drug Control Policy, and state opioid response monies. We've talked to the folks that are running these programs because when I heard about it, I was like, how do we get one in Mon County? And they are encountering some difficulties with, surprise, surprise, workforce hiring problems. So they've had trouble with staffing and retaining staff just because of pay and workforce shortage in general. But it is a great model, and I'll talk a little bit more about it here. So the model in general began in West Virginia in 2020, and it's really geared towards families with young children. It's a very family-centered approach. And the goal is really to keep kids in the home whenever possible, especially when we think of infants and the importance of attachment in those early months. keeping kids at home, if it's safe, is always ideal. There's like intense coordinated services between child welfare, substance use disorders, and mental health services, as well as child intervention services. And there are really regular meetings between all of these systems. And the idea that we're all on the same team. And so these are some of the components. There's a family mentor and a child welfare worker. There's intensive case management, which I feel is often missing. Some of us don't have that as part of our treatment programs. So the person may be struggling with housing or transportation, or I don't have an ID, all those kinds of services that make it hard for patients to, say, get their prescription at the pharmacy, or find food for their family, are intervened upon in this model with people who are all on the same team. Weekly home visits, those sorts of things. The outcomes are great. So these are the Kentucky outcomes that Huebner actually published. Higher rates of sobriety, significantly higher rates of sobriety, reduced out-of-home placements, kids remaining in the home, and reduced costs. So fantastic model. If we can figure out how to implement it, it would be great to have in all of our counties. So then just a little bit about the court systems. So you guys are probably familiar with, there's drug court, there's juvenile drug court, and now there's family drug court, or family treatment court, it's sometimes referred to. So the adult drug courts have been the most prolific. So the first drug court actually piloted in West Virginia in 1999. And now we have one in most counties. So the only counties that don't have them are the ones in white. So there are counties that don't have them, but many of them do. And the idea, we've actually done an echo with some judges and probation officers affiliated with drug court, and they do definitely seem to have a much less stigmatizing view towards their clients. There's really a celebration of success, and a better understanding of substance use disorder as a chronic illness, versus that of which criminal behavior is a symptom, rather than these are just bad people. And then there are fewer, but some juvenile drug courts. And it's interesting, I looked up some of the numbers. On any given day, 7,000 kids are involved in some kind of court-ordered diversion program. That's a lot for a small state. And controlled substances are the third most common reason for kids to be involved in the juvenile diversion program. And obviously then there's drug courts, and all of those kids are involved with substances. It started out as grant funded in 2004, and then we have some around the state, certainly not the majority of counties, but some around the state. The average length that kids are involved with drug court is about 8.5 months. And then family treatment courts, also sometimes people refer to as family drug courts. So these are newer, and it all just began, the model really began in 2019. The goal being like a non-adversarial, non-criminal kind of court where families are supported, a family-centered approach. And the counties that have these, again, minority of counties, but it has been expanding. And the general kind of pieces to the family drug court or family treatment court are these 8 pieces. So early intervention, timely access to treatments and assessments, increased management of recovery services, really family-centered approach. The judge is very involved in these courts and an active member of the team, whereas in other kinds of settings, sometimes the judge and the systems, say child protective services systems intervening, do not seem on the same page, whereas in these courts, they're part of the same team. And so they get on the same page through regular consultation and meetings. There's a systematic response to participants that's consistent. again, I think what confuses many of our patients is the judge is saying one thing, one of the lawyers is saying one thing, the child advocate is saying one thing. I mean, people are saying all different kinds of things, and our clients and our patients get really caught in a system that's not working very well together. And so this one is much more collaborative. And then I'll end just by saying a little bit about advocacy. So these systems are very complicated and confusing, even to those of us who, have some understanding of them and maybe have more education than the clients that we're working with, and they're very confusing to us. So advocacy is really important. So helping patients prepare for the process of being involved with CPS. For pregnant patients, that includes helping them understand what might happen after they deliver. So I work with pregnant women with substance use disorders, and a lot of what we talk about is what's going to happen after I deliver, what's going to happen with CPS. They have lots of fears about that. And so we try and prepare them for a variety of different things and not say, oh, this is what is going to happen, because I really have no idea what's going to happen. It depends on if they have other children, if they have other children in their care, if they've had their rights terminated from other children. The response from CPS will be different based on a variety of different factors, whether they're in treatment, whether they're not in treatment, how they're doing in treatment, what their cord blood looks like, all of those kinds of things. So we really recommend getting a release for child protective services if the patient is agreeable to that, in order to in order to be an advocate. Providing treatment summary letters to the patient. I usually like to give those directly to the patient so they know what I'm saying, and then they can give it to their lawyer, or they can give it to whomever they like. And it's usually pretty general, not really super specific. Sometimes we'll have patients sign a release to release all of their records to Child Protective Services. This is not a good idea. I have had this done in court where the patient's childhood trauma history was then read aloud in court. This was not helpful. This was re-traumatizing for the patient, and it had no bearing on her ability to parent her children at age 33. So we want to be trying to help our patients understand, if they're signing a release, what their rights are, about how much information gets shared with Child Protective Services. And usually a summary, perhaps with urine drug screens, should be enough. And so advocacy is super important. And as always, instilling hope without expectations, which is always a balance. So trying to prepare patients for a variety of different outcomes when they get involved with the judicial system, because it can be unpredictable. And then when Mitra sends out the slides, a couple of references and some resources, online resources for everybody.
Thank you so much, Laura. What an important and complex topic, and you did such a wonderful job as always presenting. So thank you so much. Any questions or comments from the group? Or I'm sure you all have had experiences along these lines. Fred, I saw you raised your hand.
Yeah, Laura, I've got a question. When I was working for Center for Hope and Healing in Bridgeport, I know the women that went over to the UHC, you were talking about stigmatization. They were very much stigmatized. But the question I have, if they've lost their children prior to that, when this next baby is born, is it already automatically taken too?
So again, it varies, but I would generally prepare women for that possibility.
Yeah, we did at the time, but I wasn't sure, because I've heard both ways that no, they can't take this newborn just because of the prior 5 years ago or whatever. But I was still wondering if it ever changed, or if we ever got anything solid on that.
It really, in my experience, it seems to vary county by county, which isn't how it's supposed to work, but that's how it works in my experience. So it depends on the judge, it depends on the Child Protective Services workers in that particular county, but it is a distinct possibility. Yeah.
Right.
So if they have voluntarily given their rights to a family member, that's very different. Or if they have no other children, obviously that presents a very different picture as well.
Thank you.
Good question. Yeah.
Thank you, Fred. And I think I saw Danielle had a question as well. She may have had to hop off. So, oh no, Danielle, I see you. Sorry about that.
Yeah, I hope you guys can hear me okay.
Yes.
Yep.
Can you hear me? My question, I guess it's a question or maybe just a clarification. You mentioned earlier about that CPS referrals can't be made because of the view on personhood while someone is pregnant. And I wonder if it feels like a discrepancy to me with the current abortion law changes. And so I wonder if you feel like that might be changing. And if so, what bearing is that going to have on CPS or the rest of us in helping professions?
Yes, so it's a very timely question, right? We don't know how that's going to go. We certainly have watched some of our neighboring states, such as Tennessee, try and criminalize substance use in pregnancy and the really negative impact that has had on pregnant women seeking treatment, and therefore more negative outcomes for children who are born where their mother was afraid to seek treatment for fear of being put in jail when she was pregnant. So it's, and there have been, I believe Tony's the expert on this, but I think there have been some things in our own state that have been proposed and not enacted along those lines of criminalizing substance use in pregnancy, but they have not gone into law, thank goodness, because I actually do not think that is going to promote women seeking treatment if they're pregnant, if that occurs. I don't know. I'm happy to throw that out to the group if other people have thoughts about that. That's a good concern and question and something to raise. I do not know how that may change in the coming days. I haven't heard anything, but it's certainly it would be a concern of mine. Any other thoughts, questions?
I'll just say, Laura.
Go ahead, Jennifer.
Oh, sorry about that.
It's okay.
Thank you. It's just a really quick comment. We thank you for the presentation. We are in Fayette County, New River Health, and we have been part of the treatment team for family treatment court here for, I don't know, a year and a half anyway, and maybe a little bit longer. And it's similar to what they call drug court, which I would prefer to call adult treatment court. But anyway, it's really gratifying to be part of that. And I didn't know the history of it. So that was very interesting. Thank you. I didn't know about that.
Yeah, it's great to hear you're part of that and that it's a good experience. Yeah.
Yep, right.
I was going to say actually something similar. And Jennifer, you would be pleased to know that we were the service provider for the Second Circuit Adult Drug Court, and we renamed it Adult Treatment Court, by the way.
Bravo.
Excellent.
It's one thing that we did down there. Yeah. So we're trying to change the names, but although all the paperwork they have to send us as drug court, but we also work with the family treatment courts up here in the Northern Panhandle, and it's awesome. I know not every county has them right now, but if you can, and if you can get on it, and if you're an MAT provider, you should be in that treatment team right away. So that's something to pay attention to. In my experience, they will take into consideration the judges, what the treatment providers have to say. And lots of women and families have been successfully treated with and reunited with their kids while on MAT in our family treatment courts. So it's been really, really successful and well received up here. So if you have the opportunity to get involved in that, you should try to do so, is what I would add.
Great. good to hear. I like positive stories, and yeah, I wish we do not have one in Mon County, and so I'm glad to hear you guys have had good experiences.
Laura, I have a question. With all the horrible statistics at the beginning, how much do you think of it is reality versus just the kind of the attitudes of CPS that have driven up numbers unnecessarily high? Off the record. No, I guess we're on the record, but like the child removals, is that just because our state tends to do that more, or is it really necessary? You know what I'm saying? So it's the culture of CPS, at least historically, was to remove kids. And I feel like that's almost an issue. So when you see these numbers, to me, it's not just an indictment of the drug problem, it's also an indictment towards CPS itself with maybe some of its things. So,
yeah, I think, and this isn't necessarily, this is more based on my experience. I think the initial removal tends to be a little bit more black and white when kids are in an unsafe environment. What I think we may differ on, and this is something I might look into, is after the, so cases where the child is not returned, like what are our rates of return of children back into parental custody, which hopefully, like, family treatment courts are improving some of those statistics, but it feels like, and this is completely just my own clinical experience, it feels like that's the place where stigma is very prevalent, where so in some of my meetings, where the fact that we have a depleted workforce, and it is not possible for child protective services to do their jobs particularly well, because it's just not, I mean, I've talked to some of the managers, and in some counties, they're down to one CPS intake worker for the entire county, and the manager's covering 6 open positions in her workforce. I mean, it's just impossible for them to do the job that they're really required to do. And as a result, it may be that cases drag on longer. And do we have a case today, Mitra?
Unfortunately, we don't have a case.
All right, well, I can give a synopsis of one.
Absolutely.
And this is actually, yeah, so one of the cases where this has just occurred is we have an individual with 3 children, and when her children were removed, she got them back and they were removed again. So that's like a kind of big kind of black mark on her so CPS gets very nervous when that happens, I think, understandably. And the removals, I believe, were appropriate. She would say the removals were appropriate. She did not initially get right into treatment after the second removal. And then she went to jail. And then she got out and was sober for a year. However, all of that took longer than 18 months. And so her rights were terminated, even after being sober for a year. I mean, it was like heartbreaking, heartbreaking. And so I worked with her during the course of her year. And so that, to me, that doesn't make a lot of sense given everything she's done, and there's just a sort of arbitrary timeline. I mean, we don't want cases to drag on forever and ever, absolutely. But in a case where someone has actually done everything, and she said, the judge said to me, I did everything I'd been asked to do, and I'm a success, and yet, my rights are being terminated. It was really tragic. So that part of the system, the end part of the system, seems particularly broken to me, as well as the fact that there are not enough people to fill positions to do appropriate work.
Hey, Laura, this is Fred again. I saw you had that statistic about family. Is it mainly grandparents that are taking care of the children?
That I don't know. That would sort of be my guess. I haven't seen the actual numbers on that. Usually, most frequently it is grandparents, although certainly siblings, and aunts and uncles chip in as well.
Because I thought I heard somewhere like 69% grandparents, and I thought that was
Probably,
kind
that
of,
sounds,
but
sounds
okay.
right. Yeah, yeah, and you think about, you know, the impact of that on the grandparents' lives, who may be older and have difficulty running around chasing a 2-year-old. You know?
I even have a great grandmother in my practice who's raising a number of children. They're not toddlers, but they're teens and preteens, and it's just sort of unbelievable. What I'm curious if you have any thoughts on or if anybody has any thoughts on the statistics of the Northern Panhandle. That surprised me that it wasn't, you know, sort of Kanawha, Cabell counties, Putnam counties.
Yeah, Janine, Janine may know why, if there's a hypothesis about why the Northern Panhandle struggles with this.
Yeah, this is Janine. Some of it has to do with how, quite honestly, how aggressive the hospital is in terms of testing and diagnosing. So I think some of those numbers do reflect just a more like universal testing of every woman who comes in to labor and delivery. And then in terms of diagnosing for NAS, it's really, there's a lot of subjectivity in terms of how you assess signs and symptoms and determine if an infant or newborn is going to be diagnosed with NAS. I mean, we've done a lot to try to standardize the definition and the diagnosing, but there still is just a lot of subjectivity with that. So I think that's a lot of what's going on with the Northern Panhandle, though I do also believe that it's a serious problem there. And you can talk to the providers in the area, and there is a lot of substance use and you know, things going on between the different states, being so close to the Ohio and Pennsylvania as well.
Right. Thank you.
Yeah, I could maybe clarify a little bit since that's my up here in Northern Panhandle is where we are. The family treatment court was extremely necessary up here. The CPS, I hope there's no CPS people on the call because I don't mean to offend anyone, but they're hyper aggressive, and DHHR and the prosecutor and that whole system is hyper aggressive, thorough. They do a really good job, but they do it to the point where everybody's afraid, and the hospitals are afraid, and everybody's in cover your own butt mode, and nobody wants to make a mistake. So if anybody even does anything a little bit wrong, the first response is to take the children away. So it's kind of the culture up here right now. And that's why we've really been working with those family treatment courts to kind of balance that out back again. Because it was, I mean, it's pretty bad. I mean, if you have some people in a room that are kind of determining whether the child comes back based on nothing other than case law, the child never comes back, because you can make that argument easily when there's nothing to compare it to. So I think that's kind of the culture that it's been up here, and that's one of the reasons why they put a family court up here in the first place. Family treatment court was to try to maybe balance some of those out. So yeah, I think that's part of the reason up here, at least that's my experience with it so far.
And I don't know if people remember, there have been, I mean, part of what creates that culture is fear. I mean, there have been child protective services when cases have gone badly and children have been injured or died. There have been child protective services workers prosecuted and put in jail. So it also makes sense that they, in that kind of culture, would err on the side of being overprotective. And so it's like fear on both sides, right? In terms of, well, you know, at least the kid's not going to die if I remove them.
Yeah, it's definitely hard. And
Yeah, so I think that being all on the same team and having difficult conversations about where there's no easy answer about what to do is absolutely the solution. And you know,
exactly. Yep. That's all we're trying to do is just work with them up here and try to understand that they do have those concerns, and there's a real concerns that we have to try to work through. And there's no easy answer, but it's definitely it's a work in progress, but so far so good.
good. Any other thoughts, comments, or we can do an impromptu case if people have any good kind of case examples that they wanted to share or questions about a case.
I think that's a great idea, Laura. And just be a scenario or experience. Everyone's welcome to chime in.
The other advocacy piece I just wanted to mention, and I'll use a case example. We had a young lady who gave birth and she had a difficult labor, and her urine drug screen at the time of admissions was negative. However, the baby was found to have fentanyl in its system. Surprise, surprise, she was given fentanyl in the hospital. This was very well documented, and yet CPS had a huge reaction to the baby having fentanyl in its system. And we tried to say, hang on, wait, we can provide you with all the documentation you want. Luckily, they did hear some of that, and they did not, they allowed her to go home with the baby. But they made a rule that she was not able to be alone with the baby. Her husband works full time. Okay, you know, what are we going to do about that? So I've been working on advocacy with the CPS and saying, do you understand we have all the paperwork necessary to show that she was given fentanyl at the time of delivery. She did not have any substances in her system when she presented, and it's been a little bit of a, they're slow to sort of remove that restriction from her. And I mean, she can't, unless she wants to take the baby out in the cold and go sit in the car while her husband's at work. Like he can't supervise them 24/7. So I don't want her to get in trouble for not being able to adhere to that. But that is something to help patients understand that they should know, they should get a printout of the medications they have been given in the hospital before they are discharged. And if at all possible, when the CPS person comes to visit them in the hospital, for the CPS person to have a conversation with a medical provider to talk about that, to review that, any medications that may show up in the baby's system as a result of them being administered in the hospital.
Laura, was this
Sounds
like, sorry.
Go ahead.
Go ahead, Jenna. You're good.
It sounds like there needs to be some examination of hospital policy. Why did that get reported to CPS?
Oh, because she was on buprenorphine, it's automatic report.
Oh, I see. Okay.
Yeah. Oh, that wasn't, yeah, no, she was a co-client of ours, so she was,
Gotcha.
yeah, treatment.
They already had it out for her, basically. I guess the moral of the story is never take pain medicine while you're in the hospital. So in theory, they could do this to anybody, like any pregnant woman that gives birth that has anything. And there's just
Right, but for our patients in treatment, they are under scrutiny to begin with. So this is why, like, making sure, you know, they have as much information that they can share and medical documentation if possible.
Has she, because I feel like CPS sometimes should be made an example of, has she considered suing them? Like when it's that like blatantly obvious that her rights are being violated by their ridiculous stuff. But sometimes there does need to be case precedents out there when it comes to this stuff, or getting, you know, different things involved. I know we've talked about that before, but when it's that blatantly, obviously, there really should be some kind of.
Yeah, I mean, it gets a little bit messy because the baby did not have any substances in the cord blood, but she did relapse once on benzodiazepines during the course of her pregnancy. And so they were sort of using that as additional justification.
I think too, what complicates it is there's a federal law that requires CPS to be notified. And the intent of the federal law is supposed to be to ensure that the family is referred to birth to 3 early intervention services and other resources they may need. However, the fact, instead of making a referral to a public health agency, the law makes it requires a notification. Now, it's not a report, it's called a notification sent for anyone with the baby's drug affected. And the state can define drug affected in any way they want to. So I think that's also the complicating factor of why some of these things get reported as a notification, but then explode because, you know, once they're involved, it's hard to know what's going to happen.
Although, I mean, I have talked to this particular CPS worker and she's not particularly stigmatizing and I don't feel that she's after the patient. I think she's just trying to sort of do her job. And so it's unfortunate that I feel like if we had been able to provide medical documentation while the patient was in the hospital, that would have really helped her. And I don't think we got our act together to do that. Yeah.
And Sarah had a question in the chat, and it may have already sort of been touched upon, but is it an automatic report for any other medications, for example, benzodiazepines? And Sarah, I see you put your video on if you wanted to expand on that as well. Also love your background.
Yeah, I was just curious. Yeah, thank you. It's Halloween. So I was just curious, like, is it just an automatic referral for bupe, or is it any other sort of controlled substances, like any other, like anything that's considered like anything else other than bupe? Like, if we're recording bupe, it would make sense that we're recording other controlled substances. So
Yes, it's supposed to be any controlled substance. I don't know how that plays out in reality, but that is my understanding of the requirement.
So can you talk a little bit about, so it's automatically reported from the hospital to CPS if the mother is on buprenorphine, but what happens then? So is that dependent on the CPS in the individual county, how they handle that?
Yes, so usually, like Ruby, our care manager, the social worker in the OB department will make the call. Usually the CPS worker will come to the hospital, but not always. Sometimes they'll just talk to the social worker. So the social worker can say, yeah, the person was fine. They, are appropriate with their kid, and their family members all seem to be fine. Because sometimes you'll get some family members coming in not looking well or using substances, which creates a lot of trouble for staff and the patient. So that's usually what happens, but it's not always, because it may depend on how many child protective services workers they have in the county, or how many positions they have open, and how many people can actually get to the hospital for a visit.
And that's based on law that that has to be reported to CPS?
Yes. And Janine, you said it's federal law. I know it's the same in Pennsylvania.
Yeah. Yes, there's a federal legislation that requires and the definition is drug affected or showing signs of withdrawal, or FASD, fetal alcohol spectrum disorder. That's how it's defined in the federal law. Now, I mean, it's my understanding that the hospital makes the notification to CPS at a centralized intake, and then they determine what to do with that notification, whether to, send it on to the county to investigate, or just develop what's supposed to be a plan of safe care, but I'm not sure how that plays out.
And that's the part that's variable, how that, yeah.
Right.
Laura, have you noticed, or what is your perception, but I know you work with these ladies a lot more than I do, about their, at least locally, and you said it's variable across the state, which is amazing to me. There should be a baseline level of what's acceptable and then maybe some variability. But, there was that federal case that our state got in trouble, got sued, the federal government got brought in for Americans for Disability variation because not the mom, but the kinship care relative was taking MOUD, and they were trying to take the children away from the kinship care. Stable person on MOUD and I think that was like 2 or 3 years ago, has the perception of the acceptability and safety and appropriateness of MOUD changed at all? Like, has it become more accepted, more tolerable, more understood, do you think?
A little bit. I feel like we're making some progress. So we now have a CPS Echo, which is super exciting. It just started last month, or no, it just started a couple weeks ago in October, where we're going to try and introduce some evidence-based treatment concepts, including MOUD, and really help CPS workers like understand what good treatment looks like. And if someone is doing well in treatment, this is what they look like. We know not everybody does well in treatment. And so they need to understand what the difference between what that might look like versus what people stable in treatment will look like. So that, there's a lot of, I think there's still a lot of stigma in the court system, in the criminal justice system, around abuse and diversion of medications for opioid use disorder. And so that then sort of stigmatizes people in treatment on it. Now the regulations, because this 250-page document, that's the policies and procedures for CPS, clearly states that you cannot discriminate against someone based on the fact that they're on medication for opioid use disorder. So that is in the policies and procedures very clearly. And it was, based on that legal case. But I got to review it. And the language, some of which they kept in, the language in it was very stigmatizing. It was amazing. And again, so when we change the language, we can help change the culture. And so it's just sort of language that had been passed down. And so I was really grateful to be able to take a look at it and make recommendations on ways that they could change it, because that will help how people perceive individuals with substance use disorders.
Thank you so much, Laura. Any other questions or comments? We have about 4 minutes left. And as always, if there are any questions after the fact, you can email me. I'll make sure to have them addressed. Thank you so much, Laura, for the wonderful presentation and leading such great discussion around the topic. We really appreciate you all as well for all the great comments, questions, and participating in the discussion. It really helps so much, and we learned so much from everyone. So,
and I did have a few edits to the slide, so I'll send you the updated version.
Excellent, thank you. And any other resources or references you want to send my way, I'll make sure to have them in the recap email. The only announcement that I have is that the next session, actually, so the November 14th one will be canceled. The ECHO team is going to be at a conference, so we're going to have to cancel that one. But the next time we'll meet is on November 28th, and Dr. Husted will be presenting on medication management. So let me know if there are any questions at any point. I'll still have my email, of course, that day, so you guys can always reach out But I hope you all have a wonderful rest of your Monday and a great week ahead of you. Thanks, everyone. Take care.